I will talk today about leukocoria, its differential diagnosis, and retinoblastoma. So we heard from Mauro De Nicola, my colleague and dear friend, a great talk on multimodal imaging in adults in intraocular tumors. We also use multimodal imaging in the pediatric population, and this is the focus of this talk. I'll show you in the next few slides. So we'll start. I don't need to tell you that leukocoria comes from Greek, meaning white pupil. It's a complaint that is made by parents or caregivers, or the neighbor for that matter. It can be described in different ways. So opaque media, a white reflex, something weird in the eye, etc. A red reflex exam can detect leukocoria, so you need a dark room. You need a distance of about 45 to 50 centimeters, a direct ophthalmoscope, and better if the pupils are dilated, but they are in a dark room. And then in a normal physiological situation, you see a red reflex. Here are examples up here. I hope you can see my cursor. So this is a normal examination, but here you can see that there's a problematic reflex. You don't see a white papillary reflex here, but obviously you do not see the red reflex. Here you do see, and this of course is abnormal. It's pathological. You see the white papillary reflex, and here with the eye, with the pupil dilated, you see actually here you see a case of retinal blastoma. There's a long list of differential diagnosis for leukocoria, including several entities. Here's the list. So PHPV, previously, now it's called persistent fetal vasculature, PFV. You have retinal blastoma, which I'll tell you a bit more in detail later during this talk. ROP, endophthalmitis, dysplasia of the retina, inflammatory cyclitic membrane, congenital cataract, Coats disease, and toxocariasis. And you can sum up this into the following mnemonic called PREDICT to make it easy to remember. And here are some details on the various pathologies. So persistent fetal vasculature is a rare congenital eye anomaly from incomplete regression of fetal ocular blood vessels. Usually it involves only one eye, rarely two eyes. It can involve different parts of the eye. It can involve the lens, the retina, the vitreous, often leading to visual impairment. Common clinical signs include leukocoria, as we know, microphthalmia, which we do not see in retinoblastoma, elongated ciliary processes, and fibrovascular stalk. Management in these cases includes surgical intervention for vision preservation, but prognosis really depends on the severity and associated anomalies. At presentation, it's a benign lesion. It's only ocular. There are no associated other systemic implications. Congenital cataract can be unilateral or bilateral, and we tend to operate at a relatively early stage to prevent amblyopia and nystagmus. In case of bilateral cataract, a systemic workup needs to be done to rule out torch, TORCH, metabolic disorders, Marfan disease, and genetic disorders. Unilateral cases are usually idiopathic, a result of trauma, PFV, or other causes. I've mentioned torch, so that includes toxoplasmosis, rubella, CMV, and herpes simplex. It can present with leukocoria, which is the topic of this presentation. Other signs on clinical examination really depends on the specific pathology. It can include hemorrhage, retinitis in CMV. In herpes, you can also see occasionally involvement of the cornea, of the retina, uveitis. Toxoplasma shows the typical retinal lesion, as you can see here on the right. Additional examples that parents or caregivers can complain of leukocoria is a coloboma. Just recently, I was a young child was referred with suspected retinoblastoma, and when I dilated the pupils, even not under anesthesia, on awake exam, I could very easily see a coloboma where you simply see the sclera, bare sclera, without the overlying layers, including the cord and the retina. A retinal detachment also can be seen, so can kind of impact the red reflex, so you can see a hazy, opaque reflex and think maybe it's retinoblastoma. But the most important entity to rule out is retinoblastoma. It's the only, from this list, it's the only life-threatening disease. So you really do not want to miss that. So I'll talk about retinoblastoma now. I just want to mention that the most common presenting sign, I might have a slide on this later on, but the most common presenting sign is leukocoria. The second most common sign is strabismus. So most cases of squint, of strabismus, are not retinoblastoma. I mean, strabismus originates from many other problems, but every time you see, as a clinician, as an ophthalmologist, as a pediatrician, it doesn't really matter. If you see new onset strabismus in a child, you must rule out retinoblastoma. Okay, so before we will talk about retinoblastoma, I'm not sure Maura mentioned this. This is the treatment paradigm not only for retinoblastoma but for ocular oncology in general, because it's a life-threatening disease. First and foremost, our concern is to preserve life, to save life. If we manage to do that, we move to the next step, and that is to preserve or conserve the globe. And only then we move on to try and preserve vision or visual functions. And personally, I use this treatment paradigm in every step. Here with retinoblastoma, kids with retinoblastoma. So when I make the diagnosis, when I decide on the treatment, whether it's enucleation or conservative therapy, when I follow and monitor side effects and complications of treatment, always it's life, globe, and vision. Now, retinoblastoma is a rare malignancy. It's what we call an orphan disease. The incidence is constant. So, and this is a very unique characteristic of this disease. So the incidence is constant across the world. It's the same incidence in Greece, in the UK, in North America, in Madagascar, in Papua New Guinea. It doesn't matter where you are on this planet. It's the same incidence, about 1 in 15,000 live births. So if you know the incidence and you know the birth rate and the size of the population in a specific region or continent or country, you can easily calculate the number of new cases in that region. And if you sum up all the cases across the world in a single year, the annual global incidence is between 8,000 and 9,000 new cases of retinoblastoma. So it's the most common primary intraocular malignancy in the pediatric population, but it's a rare disease. It's based on a genetic disorder. So we know quite a lot. We still learn a lot, and we learn how much we don't know. But since the 1970s, our knowledge really expanded and grew bigger on the genetics of retinoblastoma. It's the gene was in 1986, I think, was found to be the RB1 gene. It's located on chromosome number 13, and it's the first tumor suppressor gene. So this was termed by Knudsen. I don't know if anyone in this audience heard about the two-hit theory. So this was a title or termed by Knudsen in 1971, and his a fabulous paper was published in PNAS journal back then. So the definition of tumor suppressor gene was done on on retinoblastoma. He used to monitor children with retinoblastoma with genetic disease, with familial disease and sporadic disease, and he came up with this two-hit phenomena or theory where you need a one hit on one allele, and then in order to develop the clinical disease, you need to have the second hit, the second mutation in the fellow allele, and then you have the clinical disease. You can divide the cases of retinoblastoma into germline and non-germline, about 50-50 or 40-60. What is a germline retinoblastoma? In a germline retinoblastoma, there's a mutation in each and every one of the cells in the body, or most of the cells in the body. That's the first hit. And the second hit occurs, and it does very often, occurs in a cone photoreceptor in the retina in the eye, and that's the second hit, and then the disease develops. So these children are born and they're predisposed to develop clinical retinoblastoma because they're already halfway. That's the germline. These children are also at an increased risk to develop additional non-retinoblastoma tumors later in the course of life, usually in the second decade and later on. So that's germline. The non-germline are children that are born healthy, but they developed a mutation in a cone photoreceptor. So one allele became mutated in the retina. And then the second allele, what are the chances? This is why it's a rare disease. The second allele in the same cell in the retina got mutated, and then they developed a clinical retinoblastoma. These cases, the non-germline cases, are unifocal unilateral, so a single tumor in one eye. The bilateral cases are commonly multifocal, so several tumors. You can see the example here. So this is 1, 2, 3, and this is the left eye, and the fellow eye is involved as well. It's difficult to say if these are two separate different tumors. It could be, you can see the retinal detachment here. It's a serous-exudative detachment. It could be a single tumor from a single cell, but that has two different lobes, okay? So the majority of germline cases present with bilateral disease. About 15% of unilateral cases are germline retinoblastoma. So a young patient with a unilateral unifocal disease, you cannot, by definition, rule out germline retinoblastoma. You'll need to continue monitor the patient very well, of course, treat the patient, and also perform a genetic analysis. In terms of presentation, so bilateral disease, the mean age at presentation is about 15 months, unilateral disease about 25 months. We know per definition that bilateral disease is germline, okay? But as I've just mentioned, unilateral disease, so 85% of the cases are a non-germline and 15% are germline. But in terms of presentation, what we see on our first examination under anesthesia is whether the disease is unilateral or bilateral. Okay, we don't have the genetic information yet. In terms of the presenting sign, I've mentioned this, leukocoria and then strabismus, and in low and middle income countries, mainly we see advanced disease, as you can see here. In terms of diagnosis, so it's a clinical-based diagnosis, kind of similar to the multimodal imaging done in adults. So we rarely in adults, we need to perform a biopsy. Here, it's a contraindication. It's a very aggressive disease, malignancy. So there's a reservation to this because in some of the treatments, we do penetrate the eye and inject chemotherapy. But in terms of diagnosis, it's a clinically based diagnosis. We perform an examination under anesthesia. We very carefully examine both eyes, including under indentation, 360 with an indirect ophthalmoscope. We perform an ultrasound, as you can see here. We can see the tumor. Very typically, we can see hyperechoic So this is a B-scan ultrasound. We can see hyperechoic lesions with shadowing just behind, and this indicates calcification, which is very typical to retinoblastoma. It's not pathognomonic, so there are cases of Coats disease where you have calcification, and there are cases without, especially in very young infants. So cases without calcifications that are retinoblastoma, but it's very common. We also perform genetic testing to rule out or to see if the RB1 gene is mutated. That we take that from the blood, and if we decide on enucleation as the primary treatment, we can take a biopsy from the enucleated eye as well. We perform an MRI scan for two purposes. One is to rule out a pineal blastoma. We also call that trilateral retinoblastoma when we have bilateral retinoblastoma and involvement of the pineal gland, and we perform a lumbar puncture to see if there are any cells in the CSF. In terms of classification, so this field really evolved throughout the years. There are various intraocular classifications. So here's an example of the ICRB, the International Classification of Retinoblastoma, which is grouped from A to D. Group A, in a simplified manner, Group A and B are small tumors, retinal tumors. So you can see small tumors here and a bigger tumor here in Group B. So Group B is bigger than A tumors, and it involves the macular region and or it's in proximity to the optic nerve. C and D include retinal detachment and or seeds, which can be found in the vitreous cavity, like these, like this photo, or under the retina. And Group E is advanced, still intraocular, but advanced retinoblastoma. Depending on the classification, there are about 3 or 4 classifications. It can cause elevated IOP, elevated pressure, neovascular glaucoma, and ophthalmos in extreme cases. When the tumor, as part of the natural history, if patients are diagnosed very late, and this is the case in many low and middle income countries, the tumor can escape outside the eye into the orbit or even into the brain, and then you have the international retinoblastoma staging system, the IRSS, including extraocular disease. In terms of treatment, so the mainstay of treatment is systemic chemotherapy. I'll get to that in a minute. For very small tumors, Group A, for example, we can use focal therapy. If it's posterior to the equator, we can use laser therapy. If it's anterior to the equator, we can use cryotherapy. The ophthalmologists do that. So that's, for example, here for these Group A disease. I'll jump to this Group D disease. So this is a large retinal tumor with a large retinal detachment before and after intravenous chemotherapy. Until the 1990s, the mainstay of treatment was external beam radiotherapy. In the 1990s, evidence accumulated that indicated that these children, so radiotherapy was very efficient to treat retinoblastoma, but children died from other non-RB tumors in a significant manner, more because of the external beam radiotherapy. When we understood that, we stopped, our community, we stopped using external beam radiotherapy and started using intravenous chemotherapy, and that's the main treatment throughout the world. Group E eyes are usually enucleated. And recently, like 20 plus years back, starting in Japan and later further developed by David Abramson in New York, the intraophthalmic artery chemotherapy. I think I have a short movie that, let's see. So catheterization through the femoral artery, bypassing the heart, going into the internal carotid artery, a small catheter and microcatheter, and the first branch is the ophthalmic artery. And then under radiography, we inject specific types of chemotherapy. It's called targeted chemotherapy directly into the target organ, which is the eye. according to basic studies, basic research studies, about 250 more times more in terms of concentration of chemotherapy compared to intravenous chemotherapy. So there are advantages to IAC, intra-ophthalmic artery chemotherapy, versus intravenous chemotherapy. So advantages and disadvantages, and we have both tools to use. And here you can see before on the left and after on the right. Again, about 20 years back, starting again in Japan for some reason, and then populated by Francis Munir from Lausanne, a very powerful treatment to treat vitreous seeds. So intravitreal chemotherapy. First we start with the paracentesis to lower the intraocular pressure to avoid reflux when we penetrate the eye. And then we penetrate the eye about 3 millimeters from the limbus. It's like an intravitreal Avastin injection, but what we do here is we inject melphalan or recently topotecan, and then when we remove the needle, we perform a double freeze thaw with a cryoprobe, and this is to avoid extraocular spread of tumors. Just one more, and this I think is my final slide. Recently, part of the multimodal imaging, so further technological developments, we're using handheld OCTs, which is really making progress so we can diagnose subclinical retinoblastoma, so a small retinal or intraretinal tumors that cannot be really seen on indirect ophthalmoscopy. If we screen with the handheld OCT, we can see the small tumors and treat with focal therapy and avoid systemic therapy. That's it. Thank you very much for having me.